Okay. Great. All right, let me just share my screen. All right, can everybody see the screen okay?
Yes.
I guess we have a good enough group of people. We can just get going. Okay. All right. This is a teenager who has a history of atrial tachycardia and has a ventricular pacemaker for intermittent block and slow heart rates. And this pacemaker is programmed VVIR 60 to 100. And my question for you is, what is the problem with this pacemaker? So why don't I ask Dr. Barris what he thinks is going on here or might be a problem.
Good morning, Dr. Pass. So I'm seeing, two different QRS morphologies. One looks a little bit wider, and one's almost equiphasic. I do see rates that are up to 150, and I'll see that wide complex one happen even at a cycle length that's shorter than our pre-program length. On the other hand, we do have R, which means that there's some rate responsiveness. So if she's active, that'll increase the rate at which our pacing settings are. So I'm not sure if, our pacemaker is not sensing correctly and is pacing inappropriately, or if she's being active and therefore the pacemaker is doing what it's supposed to be doing with rate responsiveness and kind of increasing our rate.
Well, can you tell which of those two it is? I agree with you. There is a problem with sensing, or there is at least a possibility of a problem with sensing. You said that either there's a problem with sensing or the patient is being just paced faster because of the rate responsive feature. Now, the pacemaker has been programmed 60 to 100.
So we're above the 100 threshold here. So then it would be inappropriate sensing.
That's exactly right. So just so everybody sees and understands, what David is saying is that there are some narrow QRSs or more narrow QRSs and then wide QRSs, which are presumably paced complexes. And what we're seeing here is that if you measure the interval from the last QRS to the next to the paced complex, this rate is at a rate above 100 beats per minute. So this cannot be just a feature of rate responsiveness. Again, just to reiterate what David was saying, when a patient has rate responsiveness turned on, in this particular device, which is a Medtronic pacemaker, there is a piezoelectric crystal that is identifying or feeling movement, and it will slowly raise the lower rate limit from 60 to 100. Remember that when a pacemaker is programmed, with a certain rate, it means that the device is programmed to not allow the rate to go below that level. And when rate responsiveness is turned on, it basically means that the pacemaker, again, will raise the heart rate in response to activity in order to somewhat simulate what a sinus node, for example, might do in that setting. But because this interval from the last, from the last beat to the next beat is at a rate really above 150 beats per minute, we know that this is not appropriate pacing. And it means that the pacemaker must have been undersensing this QRS complex. And what is the potential risk of this, Dave?
So we can potentially put a R on T if we're not sensing appropriately and cause some ventricular arrhythmias.
That's exactly right. Could be very dangerous. So this patient needs to have their pacemaker reprogrammed in order to make sure that it's properly sensing intrinsic activity. Good. Very good, Dave. All right. I thought I would go over an EP case we did a short while ago or some time ago, just to, again, as you've noticed, particularly first year fellows, I try to repeat concepts over and over again, because I find, at least I recall, that when I was a fellow, it was very helpful to sort of see common concepts over and over again, helps helps you remember a little better. So the seniors, I apologize, but we'll go through a case today. So the case is a 10-year-old with a history of palpitations and WPW, but has no documented tachycardia. Just move to the next slide. So this is the patient's 12-lead electrocardiogram. And the question first is, where is the accessory pathway? So I think I'm going to ask Dr. Perna Bonsall if she has any thoughts on where this patient's pathway might be located.
Good morning, Dr. Pass.
Good morning, Perna.
So for the location of the pathway, we look at Aruda algorithm, which so in that we look at 1 and AVR, the direction of Q wave.
So you're right. We would use Aruda, and I actually pulled it up here. So we'll.
That will be helpful.
So this is the Aruda map, and Aruda is just the name of a cardiologist. This originally came from the University of Oklahoma. Dr. Sonny Jackman, who was the first person to do a radiofrequency ablation, or certainly one of the founders of pediatric of adult electrophysiology. They came up with this. So typically we go step by step as we're looking at the ECG in order to help localize the pathway. Why does this matter? But when you're thinking about this patient, Perna, why would it be important to be able to localize? Now, remember, this is not 100% accurate, but it gives you a very reasonable guess as to the general location of the pathway. Why is this useful?
It is useful because, say, if you see a left-sided pathway, first of all, it will help you determine how many catheters you want to place. Sometimes you might not have to place like the high RA or the HIS catheter, like we did in the last case. Or if you know it's a left-sided pathway, you would look for it. I mean, it will tell you, you're sort of prepared if it's a left-sided pathway to do a transseptal, to go across the atrial septum and do left-sided ablation. So it helps with the planning of the case. Of course, during the intracardiac during the EP study, you look at the intracardiac tracings. It does help you identify if there's a pathway where it is, but then also when you're going with your ablation catheter and you're trying to locate the exact location where the pathway may be, it helps you direct at that time.
Yes, I think that the key, you're right. And the other issue is simply the decision of whether you're going to ablate somebody or not, right? For example, there are electrophysiologists who will try and ablate very small children, and others who would rather wait until a patient is larger. I would say that I particularly am somewhere in the middle, and I make my decision to some degree in terms of timing based on where the pathway might be located. If I know based on an Aruda map or other, there are, by the way, multiple algorithms that are all fairly accurate as assessing these things. If the map suggests that the pathway is very close to the septum, particularly close to the AV node, I might be less inclined to ablate a small child. Whereas if it looked left-sided, I might be more inclined because of the concern that I would have to get a little too close to the AV node or the HIS bundle. So my own personal bias is that I generally will use this type of localization in making decisions. It isn't the only decision maker, and there are some times where we have to ablate very small children when it's very close to the node, but particularly in a case that does not have anything pushing us, we would definitely at least take this into consideration. So if we look at the EKG, this is right here from the same patient, if we look in lead 1, we're talking about the delta wave here. Is it isoelectric or negative? I think it is actually isoelectric here. Yeah. Similarly, in V1, is R greater than S? And I think the answer to that is yes. So that would suggest that this patient has a left-sided accessory pathway. So again, lead V1, R is greater than S. Also, when you use very deep S wave in AVL, that is also very suggestive of a left-sided pathway because the QRS is going away from the left side of the patient, suggesting the pathway is on the left side. Now we're looking in lead AVF to look at the polarity of the delta wave. And the question is it positive or is it isoelectric or negative? And I think we would agree that in this lead, that the delta wave is largely positive. So that would basically suggest to us that the pathway is a left lateral or an anterolateral location. Okay, does that make sense to everybody? So this is a nice, so when you see it's in that location, now we're starting to feel more comfortable that at the very least, we won't be in the general vicinity of the AV node as we're doing this procedure. Okay, and as Perna suggested, a couple of years ago, we wrote a paper in which we described using 3 catheters for the ablation of a left-sided accessory pathway in WPW. And essentially what we found was that it could be performed with a similar efficacy and safety. And I think we had an average savings of nearly $700 by doing 3 catheters versus 2. Now, I will tell you that when we tried to have this paper published, which of course is not high science, one of the reviewers said that he or she routinely ablated pathways with a single catheter. They just used the ECG and 1 catheter. And I had to make the argument that although I certainly believed that that was the case in that particular individual's situation or practice, that was certainly not a standard way to ablate WPW with a single catheter. And so finally I was able to convince the editor that this was a reasonable contribution. So here's the case. So based upon the surface electrocardiogram, we elected to put in 3 catheters as described by that paper I just referenced. And so we had those 3 catheters are an ablation catheter, a coronary sinus catheter, which allows for mapping of the mitral annulus and pacing of the atrium, both, and a right ventricular catheter, which allows V pacing in the event of, for safety, if we ever have bradycardia because we got heart block or something like that. And it also, of course, allows us to do pacing maneuvers. Now, what we're missing basically is a His catheter, but we can really measure other markers for AV nodal conduction, such as the PR interval or the AV interval, and assess what happens to them with pacing maneuvers, as we will see. So the first thing we always do is we get a baseline electrocardiogram. And again, we see, now remember, this is at 100 sweep speed, but again, we see that AVL is a pure Q wave. And in V1, it's hard to see here at this very fast paper speed, but R is greater than S. So this is still, and in AVF, we still have a positive delta wave. So the ECG seems to look similar to the resting ECG from the clinic. So whenever we do an EP study, the key thing in my view is to do it in the same manner each time, meaning we do the certain tests in a certain order. And the only reason that I think that's important is simply so you don't forget to do something. So you can do this in any order you want to do it. I just happen to usually do it this way, but it doesn't have to be done this way. And so typically what we normally do is we start out with rapid atrial pacing. So here we are pacing at cycle length 500. So let me ask Tarek, if I'm pacing at cycle length 500, what is the heart rate I'm pacing at?
So let's see, need to use the calculator. So be 120.
That's right. So we divide 60,000 by the cycle length to get the heart rate. So we're starting at 120. And immediately we see, if we look at the surface electrogram, we are still pretty excited and the QRS is very wide. And when we look in the coronary sinus pairs, just as was predicted from the surface electrocardiogram from the Aruda map, we're looking here, we see the atrial electrograms and the ventricular electrograms. And again, whenever you're looking at intracardiac tracings, you first want to start by looking at the left side of the legends. And we see here that we have 4 ECG leads. We have an ablation catheter listed as MAP, distal and proximal, which is not yet mapping, so it's just sort of sitting in space. The His is there, but there's no His catheter, so really at this point we should have already removed this channel. And now we are pacing from the coronary sinus, and in our laboratory we display the coronary sinus from proximal to distal. And in this particular catheter, it's a decapolar catheter, meaning that there are 10 electrodes or five pairs of electrodes. Now, if we are in the proximal coronary sinus and we have AV conduction through the AV node, we would expect that the earliest ventricular electrogram would be in the coronary sinus. And as we move farther and farther lateral away from the mouth of the coronary sinus towards the left wall of the left atrium, or the lateral wall of the left atrium, we would expect that the ventricular electrogram would get later and later. But in fact, what we see is that the earliest ventricular electrogram is in the coronary sinus distal pair, or possibly in 3-4. But, and this is what we would refer to as an eccentric pattern of depolarization, where the earliest ventricular electrogram, this is the atrial electrogram, and this is the ventricular electrogram. The earliest one is in the coronary sinus distal or second to last pair, suggesting this is a very abnormal pattern, or what would be referred to as eccentric. And that suggests that there is a pathway in the left lateral position of the heart. So we're pacing faster and faster because we're trying to determine what the level of risk is of this patient for the development of rapidly conducted atrial fibrillation. And as a surrogate of AFib, we pace the heart faster and faster, looking to see where we block. So we're now pacing a little faster at cycle length 450. And we see, and all you have to do, of course, if you look in the surface, you can tell that we are still pre-excited. But if we look in the coronary sinus pairs, it's even easier because we're just looking to see if the eccentric pattern of depolarization, whereby the lateral wall is depolarizing earlier than the medial wall, if this ever changes. So at cycle length 450, we are still conducting via the accessory pathway. Now we're down to cycle length 400. Let me ask Dr. Condon, what is the heart rate we're pacing now at cycle length 400?
150.
Right, exactly. That is the MIT graduate doing higher math in her head.
No, I used a calculator.
Okay, you didn't have to admit that, but okay. Anything works. So here we are at a rate of 150. We're still eccentric. We're still going down the accessory pathway. And Tulsi, what is the at what cycle length would we start to consider this patient to be high risk for the possibility of sudden cardiac death?
This is a guess, but would it be above 200?
Well, 200 would definitely be a concern because that would be a rate of almost 300, but basically it's cycle length 250. That has been demonstrated in adult studies to be the sort of line in the sand. Everybody would agree that if you can conduct through the accessory pathway at cycle length 250 or faster, that probably you have a high risk accessory pathway. So at 150, at cycle length 400, we are still not in a danger zone. This is still would be considered not demonstrative of high risk. Here we are at cycle length 350. And you see that our QRS is still very wide, and we still have this eccentric pattern in the coronary sinus. So we are still conducting through the accessory pathway. Here we are at cycle length 320. We still have a wide QRS, and we still have an eccentric pattern, again, with the earliest ventricular depolarization being in the coronary sinus distal pair. But then when we get to cycle length 310, something happens over here. So let me ask Dr. Bebbia what he thinks has happened over here.
I see the A waves, but I don't see any V waves, so it's not being conducted.
That's right.
Um,
Exactly right. So this is what we would say is that the pathway can't conduct at rates or at cycle lengths of 310 and below, right? So that's basically a heart rate in the 190s. Interestingly, neither can the AV node, right? Because we're not as you appropriately and astutely commented, we're seeing A's, but we ain't seeing any V's. And that's because not only is the pathway not conducting, but also the AV node as well. So we would call this the so-called Sperry, or the shortest pre-excited RR interval, which would be about 310. And so by that criterion, we would not say that this is high risk. In fact, we would say this is a low risk pathway for the development of rapidly conducted atrial fibrillation. I normally then will do atrial extrastimulus testing. Again, one can do it in any order you want, but this is just the order that I have generally done it for many years now. So here we are, and we're doing atrial extrastimulus testing. And as you remember, we pace the S1, or the first beat, is paced at a fixed rate for 8 beats, in this case, cycle length 500, which Tarek explained to us is a heart rate of 120. And then we put in an extra stimulus, the 9th beat, at a shorter interval than the pacing cycle length. And typically, the technique is to go by 10 millisecond increments down as we do this. Now, in the interest of time, because we're demonstrating it, I cut it faster. So we're going to not go by 10 milliseconds, but typically we would go 500, 390, 500, 380, 370, 360, et cetera, but we're going to go a little faster. Now, what happens to AV conduction when a patient has conduction through the AV node? As we become more and more premature, let me ask David, what should happen to the AV interval? Should it get longer? Should it remain fixed? What normally happens in people when they don't have accessory pathways?
Longer, because it should decrement.
That's right. So we should see decremental conduction, and accessory pathways, of course, do not decrement. And so what we're looking for here is to figure out what is the refractory period of the pathway. So here we are at 500, 390. And again, you know that it's conducting through the pathway because of this eccentric pattern here, where the earliest ventricular electrogram is in the distal coronary sinus. So here we are at 360. I cut a little bit ahead, and we're still, earliest ventricular electrogram is in the coronary sinus. So we're still going through the accessory pathway. Also, the AV interval on the extra stimulus is not really changing from the drivetrain, suggesting also that there is no decrement. Because again, accessory pathways do not generally decrement, not most of the time. Now we're at 500, 340. We still have this eccentric pattern of depolarization. So we're still going down the accessory pathway. Here we are at 330. We are still going down the accessory pathway, as demonstrated by the presence of no change in the QRS complex, as well as this eccentric pattern of depolarization. Here we are at 310. Interestingly, the AV interval, if you compare this to the prior one, I think you would agree in your mind's eye that this interval from the atrial electrogram to the ventricular electrogram is shorter than in this beat. So we still see an eccentric pattern, but interestingly, the accessory pathway is starting to decrement ever so slightly. And that's important just because, just to make the point that although we tell people that pathways do not decrement and AV nodes do, it actually turns out that pathways decrement as well. They just decrement much, much less than AV nodes. So we're still conducting through the pathway at 310. And then we're now at 500, 300. And the the question is, what happens? Is Dr. Kong on the line?
She's on vacation this week.
Ah, how interesting. Good for her. So Perna, since you were kind enough to offer this information, I'm going to ask you in standing in for the chief fellow, co-chief fellow, what happened here?
You're not conducting.
Right.
It
So
blocks you the pathway.
right. So this would be considered the accessory pathway effective refractory period, or the AP-ERP, accessory pathway effective refractory period. Interestingly, we're also not conducting through the AV node. So the AV node in this particular patient conducts quite a bit less well than the accessory pathway, wouldn't you say? So what we would, so formally you would say that the accessory pathway effective refractory period is 500, 300. And we would say that the AV nodal effective refractory period was not encountered, meaning that it was somewhere else. You know, it's or you could, another way of saying it is that the AV node ERP is longer than or equal to 500, 300. We don't know what the AV node is like. All we know is that at 300, it doesn't conduct. The next thing that we do, that we did in this case was ventricular extrastimulus testing, because we want to see if the pathway can conduct retrograde and what are the characteristics of the pathway. So here we are, and we're pacing from the right ventricle, and we see that we now have reverse conduction, where this is the, you see that this is the paced complex, and it corresponds to these ventricular electrograms. And then we see the retrograde atrial electrograms. And once again, just as the accessory pathway conducts antegrade in an eccentric pattern, so too does the accessory pathway conduct eccentrically retrograde. And so we have an earliest atrial depolarization in the distal coronary sinus pairs, which becomes later as we go more proximal towards the mouth of the CS. So here we are at 400, 340. Here we are at 400, 320. Again, we're still earliest. Notice how eccentric this pattern of retrograde conduction is, with the earliest retrograde A being in the coronary sinus distal pair, moving its way up. And then finally at 400, 290, we see what happened here. Let me ask Tarek, what do you think is going on here?
Yeah, I think the pathway has blocked.
Yes, that's exactly right. So we capture the ventricle. So here on the drivetrain, the 400 beat, we have V retrograde A in an eccentric pattern, and then we have V and no A. So we would refer to this as the ventriculoatrial effective refractory period of the accessory pathway. This is where it blocked retrograde, okay? And then we gave 12 milligrams of adenosine with V pacing. And Tarek, what do you think happened in this patient with WPW? So we had ventriculoatrial conduction with V pacing, and then we gave adenosine. What would happen to VA conduction in the setting of a very high dose of adenosine in someone with WPW?
So, like, we'll block the pathway too?
No, actually, nothing usually happens. Pathways are generally adenosine insensitive. AV nodes are adenosine sensitive. So when we gave adenosine, and I'm sorry I don't have the tracing, but when I took these pictures, for some reason I forgot to take a photograph of it. But when we gave adenosine, we saw neither AV or VA block, and that would be consistent with a more traditional accessory pathway. Now, of course, all of these rules are made to be broken, but as a general rule, accessory pathways are not adenosine sensitive. And so when we gave adenosine, we saw no AV or VA block. Okay, if there had been no pathway, we would have seen AV or VA block. And so the question then is, should we ablate this patient at all? You know, why ablate someone like this? We have not demonstrated high risk in this patient. And we not even used SVT, but we elected to ablate this patient because of the patient's history of symptoms, because we have a mechanism that could potentially explain it. And we could have given isoprel to try and induce SVT. We also could have given isoprel, which probably would have affected the refractory period and the conduction characteristics of the pathway, possibly to make it seem more high risk. But given the symptoms, given the pathway, given that it was located in an area not close to the AV node, given the general safety of transeptal catheterization and ablation of left-sided pathways, as well as the efficacy, and given the rare incidences of patients with WPW who pass all their intracardiac testing, but still are at risk for have had sudden cardiac death events, we elected to go ahead and map this pathway. So here we are doing the transeptal, and we can see here that we're tenting the atrial septum with the transeptal needle, and always we're leading with the needle, because if we're perforating the wrong place, we can usually pull out without too much serious problem. Once the dilator of the sheath follows, and specifically once the sheath itself, which is back here, follows, then you've rented a hole that's so large that if you're in the wrong place, you're in trouble. And of course, we're trying to avoid the aorta, which is anterior, and we're also trying to avoid going out the back wall of the left atrium. So as you all know, this is done on biplane fluoroscopy. So we're looking in both views to make sure that the needle is pointing both leftward and posteriorly, but not too posteriorly. And what we're looking for when we inject the contrast is, you can see the roof of the left atrium very rapidly and quickly and faintly filling with contrast. And that's a good sign that you're in the left atrium. So then we gently advance. We also, by seeing the roof of the LA, we know how far we can safely pass this sharp needle without perforating the roof of the left atrium. And so we pass the catheter into the left atrium. And so we see here, here's the coronary sinus catheter that's coming from above. And here is the RV pacing catheter in the right ventricular apex. Okay. So we mapped the ventricular electrogram on the distal map on the mitral annulus, and we slowly are moving proximal and distal along the entire mitral annulus using both the CARTOME system as well as traditional mapping. And typically we're comparing, this is the atrial electrogram and the ventricular, because we're on the mitral annulus. And we want to measure the interval from this onset of the ventricular electrogram to the onset of the QRS on the surface electrocardiogram. In this particular case, this electrogram preceded the onset of the QRS by 30 milliseconds. And basically, as a general rule, if we're about 30 to 50 milliseconds before the onset of the QRS, that's usually suggests you're very close to the accessory pathway. And here we are where we turn on radiofrequency energy, and in less than 2.3 seconds, we see a pre-excitation go away. And how do we know that the pre-excitation has gone away? The easiest way is to look in the coronary sinus pairs. In sinus rhythm, we see that we have this eccentric pattern with the earliest ventricular electrogram in the distal coronary sinus. And we see that it's getting less eccentric here until finally the AV interval is much wider, and the pairs are more on time with one another. So it took about 2.3 seconds for it to go away. And we gave the patient a number of RF applications at this location. And this is an example of what it looked like as we were putting some additional insurance lesions. Notice how different the coronary sinus pairs are. And so after that, we did atrial extrastimulus testing. And you see here now, look how different this AV interval is, right? Now we have this very wide AV interval, and you notice that all of the ventricular electrograms are now concentric or on time with one another. We no longer have an earliest ventricular electrogram in this eccentric pattern, where it's earliest in the distance and later in the proximal CS. Now we're basically about the same time, if not earliest, in the coronary sinus. If we had a His catheter, the ventricular electrogram would precede the CS pairs. So here's 600, 400. At 360, we see that the AV interval is getting even longer, consistent with decremental AV conduction. At 340, the AV interval is even longer still. Again, decremental conduction. And then finally at 600, 330, we see A's and no V. So what would we call this, Tulsi? What refractory period is this?
I don't know. I'm sorry.
That's okay, because we don't have the accessory pathway. So the only way we're conducting from A to V, since the pathway has been successfully ablated, is how? Through what structure is the atrioventricular conduction going now, since the pathway has been ablated?
Through the AV node and
through the AV node and the His. So if we're blocking in the AV node and the His, then we have exceeded the refractory period of them, right? So this would be the AV nodal effective refractory period, right? Because we're capturing the atrium, but we don't have ventricular depolarization.
Got it.
So this is the AV node ERP, and that's a normal AV node ERP for a young person, a 10-year-old. And then we give 12 milligrams of IV adenosine. And what we see here is that we're seeing P waves with no QRS. And that suggests that there is no pathway, right? Because as we discussed with Tarek a short while ago, accessory pathways are generally adenosine insensitive, and AV nodes are adenosine sensitive. So the reason we give adenosine at the end of the case is as a further proof of the absence of the pathway. What we're saying is, I'm going to block the AV node and make sure that there is no residual pathway at all underneath. And so when we give adenosine and we transiently block the node, we see that there is AV block. And then we start pacing the ventricle, and there is VA block. We see that here's an A, but these are all ventricular paced complexes, but the A is all over the place because there is ventriculoatrial dissociation. So we have both AV dissociation or AV block and VA block. So that would be highly consistent with at least an acutely successful ablation of an accessory pathway. Okay. And with that, we're done. That is the case. So hope everybody enjoyed that. Any questions anybody has about this? Nope, guess not. All right. I hope everybody has a great day, and see you at 8 o'clock sign out.
Thank you.
Thank you.
Dr. Bass.